So this is a presentation about the patellar fractures, primarily a focus on the evolution of literature. Why are we discussing the patella? The thing is that the patellar fracture is uncommon, but paradoxically it's quite familiar. Even the resident knows that the patella is fractured and is often seen in the casualty. It's a nondescript bone, so no one gets any bragging rights of fixing it very well. And interestingly, the literature seems to have stagnated. We are at a stage where most of the times we end up treating the patella inadequately. So let's go back a little. We must remember that non-operative treatment was the mode of treatment, the primary mode and the best mode till the end of the 19th century. It was Guino who in 1905 recommended operative repair. Brooke in 1937 felt that excision was the best treatment. He did show improved strength in his papers. But it was the biomechanical facts which in the end changed the course of the treatment and the understanding of the function of this bone. It was initially thought that it was just a large sesamoid bone and it was relegated to the vestigial organ group. It was quite obvious that it was a link that connected the patellar tendon to the quadriceps muscle, but it was thought to be unwanted. A link that was pure tendon was thought to be better. So some of the legends felt that patella inhibits quadriceps function, Hay grooves, and excision improves function, Watson-Jones. There was a debate. Some people said excision should be done, or most people said excision should be done, but should it be partial or complete? As you can see, in 1936, 1947, 1944, various authors were of varied opinions. The only commonality was that excision of some sort was better. Now it was Haxton who in 1940 showed that it had very important biomechanical functions, the patella, especially displacement. It's important to remember that the quadriceps mechanism has to generate twice the normal torque in the final 15 degrees of extension, and the patella was important in pushing this tendon away from the center of rotation of the femur, increasing the lever arm of the quadriceps and consequently improving the function of the quadriceps. So things started changing. Till then, people were mostly going for excision and patients were dissatisfied. There was decreased strength, residual pain, functional disability. In the background, one must remember some heroes like Malgane in 1843, Hector Cameron in 1877, and Lister in 1877 did propose fixation with griffe metallique, as you can see in the picture, or wiring. Even further back, some unknown people did try fascia and kangaroo tendon. Now, conservative management of patellar fractures is amenable for nearly 50% of these fractures. Literature has been surprisingly consistent about it. But if there has been evolution in literature, it is about the position of immobilization. Some people say that you immobilize the patella in extension. Some say you do it in 10 degrees of flexion. After, of course, saying that the patella is stable up to 60 degrees of flexion under the C-arm and does not displace. Of course, before that, an SLR test has to be conducted. Operative management, there's a huge range of possibilities as is found in most of our textbooks: tension band, Lotka band, Magnusson wiring, double tension band, and vertical tension band, screws and wire. But it is the tension band wiring which holds the center stage to this day. The tension band wiring was introduced in 1950, developed up to 1979 by the AO group. Modified tension band wiring was introduced a little later. It is still the most widely used method with 90% satisfactory results. But is the discussion done and dusted? There are some prerequisites for tension band wiring. The fracture pattern should be able to withstand compression. That means usually a transverse fracture or a fracture which you can convert into a transverse fracture. There has to be an intact cortical buttress and a fixation that should be able to withstand tension, because there are two things that occur simultaneously in a fixed patella. There is a bending force and there is a tensile force by the muscle. The tension band wiring, there has been of course evolution of literature if we watch it closely. Barron in 2007 in an MRI study advised that tension band wire should be placed as close to the bone as possible. And it was found that reoperation rates in tension band wiring varied from 35% to 60%. It is now known that a tension band away from the bone can cause both patella baja or patella alta due to unwanted effects of this tension band wire on the quadriceps or the patella tendon. Now we'll look at the tension band one by one. First of all, the K wires. What should the sagittal position of the K wires be? The AO Principles of Fracture Management recommends that the wire should be placed 5 mm below the anterior surface of the patella. In 2017, it was recommended that a central position was the best, neither too far back nor too far forwards. But it was linked in the most exhaustive biomechanical study who showed that a position in the posterior half of the sagittal plane was probably the best. Now this is his study. It has been conclusively shown in the study that if you put the wires in the posterior half of the patella, the results are the best in terms of biomechanics, both for figure of 8 as well as figure of 0 configurations. You can see the amount of displacement or separation that occurs in the anterior wires and the separation in the posterior wires. The posterior wire separation is almost negligible. But a question arises here, and that is if you put the wires too far posterior, they will come out posterior to the apex of the patella and might be difficult to loop. Now the second thing is the coronal placement. The literature is surprisingly silent on this issue. The AO manual mentions that the ideal level is at the center of the patella, but where exactly? It was again Link who showed that if we divide the patella into 4 segments in the coronal plane, the interface between the central 50%, the peripheral 25% is the best place to put the wires. But of course, generally, rule of thumb states that you divide it into 3 equal segments, not 4. Now we come to the SS wire. Which figure of 8 should be used? The figure of 8 is superior to figure of 0 is undisputed. We know that. But the figure of 8, should you be using a simple figure of 8 or the figure of infinity? Again, John J. in 2007 showed that the vertical figure of 8 generated a compression of 79.5 units, whereas the horizontal figure produced a compression of 171 due to the number of wires crossing the anterior part of the patella, as you can see in the picture. The second thing about the SS wire is where should you place the twists? There is consensus that 2 twists are better than 1. John showed that 2 twists increase compression by 12%. They also showed that placing the 2 twists at the corners of the figure of 8 instead of in the middle of the wire or the side of the wire increase the compression by a further 18%. So the recommendation would be twist it at 2 places and twist it at the corners. Now which wire material? Of course the SS wire is the material that we use most commonly, but we often face wire breakage, loss of reduction, and metal irritation. So the wire material has also evolved, as has the literature. While the SS wire is the most commonly used, it has been shown that braided cable wire might be better. Mehria showed that braided polyester has a strength of 75% compared to stainless steel, even though the results are the same. Chen showed that wire and biodegradable implant is equivalent. There is a lot of literature which definitely supports the advantage of using tension band wire with cannulated screws. And at this moment, this probably is the best tension band construct. But the problem is burying the wire around the screw heads, screw head prominence, and the difficulty of finding the screw holes. But to counter this, screws have also evolved. As you can see in these pictures, wire position does not necessarily, a wire does not necessarily have to be inserted through the cannulated screw, but only through the top or through the head where it has been modified to hold a screw. But the interesting fact is that the biomechanical studies, in contrast to the K-wire studies, show that the screw should be in the anterior half, not in the posterior half. Percutaneous methods are also evolving. It is simple and obviously preserves blood flow akin to any MIPO surgery. However, two problems have to be faced. The fracture area cannot be cleaned easily, and some fragments will become intra-articular, and the retinaculum cannot be repaired. It is important to reiterate here that repair of the retinaculum is critical to the success of the surgery. The retinaculum and the arthrotomy. Retinacular repair has been proved to improve the stability of the fracture construct or the fixation construct, but no one has ever assessed the role of suturing on patella tracking. It is something that needs to be studied. Another method in 2019 by Yin shows that you simply cut the retinaculum, flip the patella, fix it under vision, get a very good articular construct, then flip it back and repair the retinaculum. Again, long-term results are not known. Plates are the new thing. You can see a huge variety of plates. The arrow plate, the star plate, the other types of angle stable plates are also available. There is a plate which is akin, the claw plate, which is akin to the main and griff. It seems that history is definitely being repeated in this case, and mesh plates. This is definitely the cutting edge. Initial results are definitely showing better outcomes. They are stronger than tension band, and the results are definitely promising. And there is a specific or a different kind of construct for the distal pole. As you can see, it's a basket plate with multiple screws and a plate with hooks. But once you go through the literature of plates, if you look at these red arrows, you will see that a star plate has been augmented by a wire. The plate, the arrow plate, has lost the grip on the distal pole. You can see that some of the authors have used multiple methods of fixation, that's wire and screw and plate in the same bone. You can see the hooks in the intra-articular position and the basket plate, which seems to have ripped the whole tendon apart even in a demonstration mode. So maybe in the future we may not be too enamored with these devices. Perhaps it is time to be non-dogmatic. You look at the characteristics of a fracture, then decide how to fix it. As in this case, a surgeon should not be dogmatic about screws or the tension band or the plate, and at times we prepared to use all three. Thank you for your patience.